Okay. The webinar ကတော့ကျွန်တော်တို့ RCGP ရဲ့မြန်မာပြည်မှာရှိတဲ့ကျွန်တော်တို့ရဲ့ GP College မြန်မာ GP Education နဲ့တွဲပြီးတော့မြန်မာ GP များ development အတွက်ကိုလုပ်တဲ့ part of the continuing medical education ပါဒီနေ့တော့ကျွန်တော်တို့ RCGP ရဲ့ကျွန်တော်တို့ရဲ့ colleague trainer Dr. Subir Ghosh က men's health အကြောင်းပြောပါလိမ့်မယ် Subir, would you like to introduce yourself? Thank you.
Yeah, thank you. Thank you, Dr. Ong. So I'm Subir Ghosh. I'm a GP and GP trainer. I work in Essex in a big practice, in a big GP practice, Mount Chambers Medical Practice. I am not a urologist nor a nephrologist, but today Dr. Ong asked me to do a presentation on men's health, and I'm going to share my experience of dealing with men's health problem in general practice. So I will talk about various conditions which affect men in particular. And obviously at the end of the talk, there will be time for question and answer. And Dr. Ong and myself will try to answer your questions. Thank you very much for joining. So I'll just start sharing the slides. Can you see it?
Yeah.
Yeah.
Okay. Thank you. So, yeah, so I'm going to talk about men's health. The reason I have chosen this topic is, as I said, if you go to hospital, there are departments for women's health, children's health, sexual health, then mental health, but there is no department specifically for men's health. So does it mean that men don't have any problem? Do they not suffer from any specific problems which need attention? So yeah, what I found that men are reluctant to see their GP. They don't come, various reasons. In some places, they are the only member of the family, so they cannot make time to come and see to their GP. Sometimes they ignore their health problem, and at the end, they suffer a lot. Lower urinary tract symptoms is quite common in men, but it is underreported. Why it is underreported? Because it's a bit embarrassing. People feel shy about saying about their urinary problem, incontinence, etc. Erectile dysfunction is quite common. 25% of men over the age of 40 suffer from erectile dysfunction, which causes psychological stress. But quite often people don't mention it to the GP. Cardiovascular disease is more common in men, and 25% of male deaths are due to coronary heart disease. Infertility is due to male factor in 25% of cases. So men do have lots of problems, but quite often it is underreported and undertreated. So first I'm going to talk about hematuria. So hematuria can happen to anyone, children, men, women, but I'm trying to focus hematuria in men. So hematuria means blood in the urine, which can be visible. That means there is obvious blood in the urine, or it could be microscopic, which can be detected by dipstick, like has been found here, or under microscope. So blood in the urine can come from various origin. It may be systemic disease, it may be medicines causing blood in the urine, or it could be due to some local cause in kidney, renal pelvis, ureter, bladder, urethra, or penis. So this is a patient I dealt few years ago, 81-year-old gentleman. One day in the afternoon came to see me with 3-day history of visible hematuria. So he said that I can see blood in my urine. He was not on any blood thinner, not on warfarin or DOACs, and there was no history of travel recently. I asked about travel history because we all know that some infection in the bladder, like Schistosomiasis, hematobium can cause bilharziasis, which can cause painless blood in the urine. It is common in North Africa and in Egypt. So whenever people come with hematuria, we try to see whether they have been abroad recently. I checked his medical history. So of note, of importance is he had benign prostatic hyperplasia and had a raised PSA. He had a prostate biopsy 7 years ago and was treated by finasteride. He was seen in Southport in Manchester. At that time, he was staying there. Now, this time he has come just with the 3-day history of sudden onset of red urine. So how to deal with it? So he is 81, sudden onset red urine. So it's significant. So, and he's not on any blood thinner. So I took history, I examined, I did check his blood pressure and pulse to make sure that he's not unwell. I did an abdominal examination and I did a prostate examination by doing a digital rectal examination or PR examination. The prostate felt to be enlarged but not tender. I did a dipstick and blood was present, but there was no nitrite and there was some leukocyte. And I sent the urine for culture, which came back normal. There was no infection. So if there is no nitrite in dipstick, it's unlikely to be infection, but still I did send for culture and sensitivity and there was no growth. His hemoglobin was normal, so he was not anemic, and his white cell count was normal. The kidney function was normal. So obviously 81-year-old with visible hematuria, visible blood in the urine, no obvious cause. I referred him on a 2-week wait referral, but because he had private insurance, he went to see a private urologist straight away within few days. And he had a cystoscopy that showed 2 papillary lesions, which was excised by cystoscope. And then it was subjected to histological examination, and it showed high-grade transitional cell cancer. So he had to go back to have wide resection and mitomycin therapy. And after treatment, he was fine. So just to recap, so hematuria is blood in the urine. It can be visible hematuria. It can be symptomatic non-visible. That means microscopic hematuria with burning sensation when passing urine or pain, or it may be asymptomatic microscopic hematuria. It can be transient hematuria occurring just for once or twice and then stopped. It may be painful, it may be painless. So common causes in men, I particularly chosen men because today we are talking about men's health. According to age group, if we see hematuria under 20 years of age, it's more likely to be either glomerulonephritis or urinary tract infection or congenital abnormality like posterior urethral valve or diverticula, or some systemic disease like henoch-Schönlein purpura or any blood coagulation disorder. If we see hematuria in men aged 20 to 60 years, it's more likely due to infection or stone or cancer. Above 60, it's more likely to be urinary infection, benign prostatic hypertrophy, or cancer. So treatment obviously depending on the cause, but most important is to check the severity of hematuria. If someone is having blood in the urine and if they are anemic, if they're tachycardic, or if their blood pressure is low, then we need to send them to hospital immediately for fluid and blood transfusion. So then we need to think about the definitive treatment. So according to the cause, if we find urinary tract infection causing hematuria, then we need to give antibiotic. The most important thing is in UK, now we are using antibiotic for 3 days for treating uncomplicated lower urinary tract infection in women. But for men, we should not give 3 days antibiotic. We should give 7 days antibiotic because in men, A, UTI is less common, and B, the infection is a bit deeper. That's why we always give 7 days antibiotic. Some people give 3 days, but in our practice, we use 7 days antibiotic. And it is important to do a follow-up dipstick after completion of antibiotic to make sure that the blood has disappeared. Blood in the urine has disappeared. So I usually tell them to bring a sample a week after completing antibiotic, and our practice nurse or the healthcare assistant does a dipstick to make sure the urine is clear of any blood. Now, if the blood in the urine is due to stone, obviously we need to give painkillers like diclofenac suppositories. We then refer them for CTK-UB to find out the cause and refer to urologist. Now, referral, so the blood in the urine could be due to urological cause, could be due to nephrological cause. That means due to renal disease. So referral, we usually refer any macroscopic hematuria. If we can't find any cause, we refer them to urologist. That means if there is no infection or any obvious cause. If someone has got symptomatic persistent microscopic hematuria, then we refer to urologist. And asymptomatic microscopic hematuria above the age of 40, we refer to urologist. This is according to British Association of Urological Society and Renal Association guideline. Nephrology, we refer if there is no urological cause or if they have got features of deteriorating or worsening renal function, which is from estimated GFR or from protein creatinine or albumin creatinine ratio in the urine. We do urgent referral, 2-week wait referral for suspected cancer if someone above the age of 45 come with unexplained visible hematuria but no infection, or if they have got visible hematuria that persist after successful treatment of urinary tract infection. This is the reason in our practice we do a dipstick after treating urinary tract infection to make sure that the blood has gone. If it still persists, then I will refer them to the urologist. If someone is above the age of 60 and have unexplained non-visible or microscopic hematuria with dysuria or raised white cell count, then also we need to refer them on a cancer care path to exclude cancer. Any question about hematuria, or shall we do the question answer at the end?
There are amazing actually. The show let chat tell him at Ted Aloyar, no? There are amazing question. Good, let how we mail It looks okay, Sophia. Please go ahead. I'll keep an eye on the chat. Okay.
The second patient, he is also my patient. He is still keeping well. 76-year-old gentleman certainly came one day in the morning surgery with complaining of painless leg swelling for 3 months. So there was no shortness of breath, no features of cardiac failure. He was on amlodipine, calcium channel blocker for hypertension. So I examined, could not find anything abnormal. There was no feature of heart failure. So I asked him to stop amlodipine because I thought that it could be due to amlodipine, gave him some furosemide. After 4 weeks, he came back, and this time he said that the swelling is more on left side. So one-sided leg swelling, obviously that is serious. So I started rethinking that why it is on one side, because if it is due to amlodipine, it would be on both sides. Then I asked about his urinary symptoms. Then he said that his urine flow was a bit poor. It was taking longer to finish emptying bladder, and he had to wake up 2 to 3 times at night to pass urine. So now my management, or I was thinking in different way that unilateral one-sided leg swelling with some urinary symptoms, whether it is due to something in the pelvis or prostate. So sorry, it's not moving. So I re-examined him. Sorry, I think the screen has become smaller. You can see it, yeah? Thank you. So I re-examined him. I did a PR examination this time. His prostate felt enlarged but not hard. So I arranged blood test. I arranged for PSA after 1 week because I did a rectal examination. So I deferred the examination of PSA for 1 week, and I arranged for an urgent ultrasound scan. Because with one-sided leg swelling, I was thinking of one, it was not DVT because there was no tenderness in the cuff and the cuff girth was normal. Second, I was thinking any pelvic tumor, which is pressing on the external iliac vessel. So I arranged for urgent ultrasound scan. And in a week time, when he was waiting to have the ultrasound scan, he came back with acute urinary retention. So I did a catheterization and sent him straight to the hospital because of retention. He was admitted and he had a prostate biopsy. It was negative, but the prostate was enlarged. So in hospital, they did a transurethral resection of prostate operation, and he is well now. He still comes to see me for his hypertension and other problems. So lower urinary tract symptoms is quite common in men, underreported because of people feel shy to tell about frequency of urine or if they have to go frequently or nighttime awakening or incontinence. So it is underreported. So symptoms of lower urinary tract symptoms, we can divide it into voiding symptom and storage symptom. Voiding symptom means difficulty in passing urine. They have to strain, their flow is poor, they take longer to empty bladder. Storage symptoms means they can't store adequate urine. So every 15 minutes, every 1 hour, every 1.5 hours, they have to go to the toilet. And also in the night time, they have to wake up 2-3 times at night, which can affect their sleep. They may have post-micturition symptoms. That means after passing urine, they have to go again. That means they are not emptying completely, or there could be combination. So how common is lower urinary tract symptom in men? So 30% of the men above the age of 65 do suffer from bothersome, disturbing lower urinary tract symptom. 50% of them have combined storage and voiding symptoms. So difficulty in passing urine and also going frequently. 17% have only storage symptoms, that means going frequently, and it can cause lack of sleep, and depression, embarrassment. So it's a major problem in men. So causes of lower urinary tract symptoms could be benign prostatic hypertrophy, overactive bladder, prostatitis, tumor, maybe bladder tumor, which irritates the bladder and causes voiding symptoms, medical disorder like heart failure, or use of drugs like diuretics, or cholinergic drugs, like the medicine we use for myasthenia gravis, like neostigmine type of drugs, that can cause overactivity of bladder and frequency of urination. So if there is both storage and voiding problem, then it's likely to be benign prostatic hypertrophy. If it is only storage, it's likely to be overactive bladder. It is important to differentiate because the treatment is slightly different. So we diagnose by taking history, drug history, medical history, and then we should do a focused clinical examination, abdominal examination. We all do general examination, check blood pressure, do abdominal examination, check for any sign of heart failure by looking at jugular venous pressure, basal capitation, and edema. But we must do an examination of external genitalia and PR examination. External genitalia examination is important because if someone develops a phimosis in old age due to various reasons like recurrent infection or cancer of the penis, they will have voiding problem because phimosis will cause difficulty in passing urine. So they will have prolonged voiding, etc. We should do a PSA in people with lower urinary tract symptoms if they are above the age of 50. And we should check for renal function by doing a creatinine check, estimated GFR, and we can do we can check for recurrent UTI by doing a dipstick or sending urine for culture sensitivity. Now, management of lower urinary tract symptoms. First, if it is uncomplicated, then explain to the person that waking up once at night is not uncommon after the age of 60. So explanation, lifestyle, so cutting down alcohol, smoking, caffeine, not to drink too much in the evening, bladder training, try to hold it for a bit longer, do some pelvic exercise so that bladder muscles get reconditioned and overactivity will get better. And we can do expectant management. So by doing this with pelvic floor exercise and bladder training, the symptoms might improve. Moderate to severe lower urinary tract symptoms, if there is main problem is voiding, and on examination, if the prostate is small and PSA is less than 1.4 or not very high, then we can try alpha blocker, which is tamsulosin. We use tamsulosin modified release tablet, 400 microgram once a day, and we review them in 4 to 6 weeks. The reason for this is if someone is having problem with the voiding, and if alpha blocker works, it usually works within 3-4 weeks because it relaxes the bladder base. So in 6 weeks, if they are not improving, then possibly tamsulosin will not work for them. On the other hand, on examination, if the prostate is large, PSA is slightly elevated, then we can use 5-alpha reductase inhibitors like finasteride or dutasteride. These medicines prevents the conversion of testosterone to dihydrotestosterone, and that way it checks the growth of the prostate. It limits the growth of the prostate. But because it affects the growth of the prostate and slows down the growth of the prostate, it takes 3 to 6 months for the effect to become appreciable. So it will not give relief within 6 weeks. It takes 3 to 6 months for symptom relief. If the problem is storage, if they can't hold because of either small bladder or overactivity of bladder, then we can use anticholinergic to relax the bladder like oxybutynin or detrositol or solifenacin. So there are various anticholinergic drugs which works on the bladder receptors and helps to relax the bladder. In people who have got contraindication to anticholinergic, like if someone has got narrow angle glaucoma, or if someone has got dementia where too much of anticholinergic drug is not suitable, for them we can use beta-3 receptor mimetic mirabegron. I'm sure you get it in Myanmar. In UK, it is marketed in the name of Bitmega, mirabegron or Bitmega. And then you advise regarding incontinence and if necessary, refer to the specialist. So if conservative measures fail, then we refer to the specialist mainly for urodynamic studies. So they will check the pressure volume changes in the bladder by doing a multi-channel cystometry. When to refer a patient with lower urinary tract symptoms, if suspected urological cancer, if age-related PSA is above normal, or if we feel any nodule in the prostate, or lower urinary tract symptoms with hematuria in an elderly man should be referred. We also need to refer for acute retention, chronic retention, and recurrent UTI. So the gentleman I just discussed, he came with acute retention. That's why I referred him on the same day. Or if the lower urinary tract symptoms is complicated, then also we need to refer. So uncomplicated, mild lower urinary tract symptoms we can treat by conservative management, lifestyle advice. Moderate symptoms, we can treat either giving alpha blocker, that is tamsulosin, or we can use anticholinergic drugs, or we can use 5-alpha reductase inhibitors. This gentleman, he was 60 years old when he presented. He was suffering from ulcerative colitis. He was on sulfasalazine for ulcerative colitis, and he was also having hypertension. Came to see me with left mild abdominal pain, left-sided mild abdominal pain. So I examined and thought it could be gastritis, but because of ulcerative colitis, I arranged a blood test. His hemoglobin, white cell count, and CRP were normal. So I gave him some lansoprazole. After 6 weeks, he came with a swelling in the left side of the neck. It was quite a discrete swelling in the left side of the neck in anterior triangle and slight cough. So I again examined, and I thought that it could be due to upper respiratory tract infection. So gave him a course of antibiotic. And because he was complaining of abdominal pain, I also arranged for an ultrasound scan. So while waiting for ultrasound scan, he had an attack of acute pain in the tummy, in the abdomen. So he went to hospital, got admitted through A&E. They did a CT scan immediately, and they found an enlarged lymph node in the abdomen, in the retroperitoneal region. And there was a cyst in the kidney. So because of his history of ulcerative colitis, retroperitoneal lymph node, cyst in the kidney, he was referred to urologist and hematologist. So urologist examined. So he had an ultrasound scan which showed a lymph node, and the prostate was not very enlarged. It was only 30 mils, so just above normal. So he was seen by urologist. And when urologist examined, his prostate was enlarged and indurated. So that means it was a bit nodular. And his PSA was 3,560. Normal PSA at his age should be around 6.5. And his one was 3,560. So he was booked for transrectal prostate biopsy. In the meantime, he was seen by ENT surgeon, and they did a biopsy of the neck gland, which showed metastatic adenocarcinoma of the prostate. He had a bone scan, which showed lesion in the bones, in the spine. And then he was seen by oncologist, was given chemotherapy, docetaxel chemotherapy. His PSA came down, he was doing well, but unfortunately, after 2 years, he passed away. He died because of metastasis. So this one shows that how aggressive prostate cancer can be and how rapidly it can progress, because this gentleman never presented with any urinary tract symptom, and he presented with abdominal pain and neck gland, and on investigation, he was found to be having advanced prostate cancer. So I will not go through all the slides. So prostate, we know we can have prostatitis, benign prostatic hypertrophy, or prostate cancer. Prostatitis is usually due to infection through blood, sepsis. So it's a bloodborne infection. It causes temperature, body ache, but most important is backache, perineal heaviness, and pain passing urine. And on examination, most important sign is tender prostate. So prostate will be tender in prostatitis. Treatment, prostatitis should be treated with 4 to 6 weeks of antibiotics, not 1 week, not 2 weeks, 4 to 6 weeks. If we don't treat with adequate antibiotic, they can develop chronic prostatitis, which is a sequelae of undertreatment of acute prostatitis. So that's why it is important to treat for 4 to 6 weeks. Next important thing for men is PSA. So in general practice, a lot of people come to us, 30 years, 40 years, 50 years, 60 years old. They say that, doctor, I like to have a PSA. And also when we do blood test for diabetes or for cholesterol, they always ask, can I have my PSA check as well? So PSA is prostate specific antigen. It's a blood test. And obviously it goes high for various reasons. but one of the reasons is cancer of the prostate. So it's a good test. It's not a bad test. It is best available blood test for detecting prostate cancer, but its specificity is limited. So if we check 100 men aged 50 to 59, 10 of them will have raised PSA. And out of these 10, 4 will have prostate cancer. So by doing without symptoms, 100 patients PSA test will be able to detect 4 prostate cancer. So its specificity is less because it has got more, I mean, even if it is not high, prostate cancer may not be there. So specificity is less, but it's very sensitive test. So if prostate cancer is there, PSA will be high. But if PSA is high, prostate cancer may not be there. So people have tried different ways of improving the specificity, like checking with the age-specific PSA, which we do in US, UK. So we have got cutoff for different age group. And also we have got lower cutoff for Afro-Caribbean men because they are more prone to get prostate cancer with lower PSA. You can check velocity, so you can check how is the PSA today and after 3 months, whether it is increasing or not. So you can check the rising PSA or velocity of PSA. And you can check free to bound or total PSA, ratio of the free to total PSA. So causes of high PSA, we all know it can be due to old age, it can be due to urinary tract infection, catheterization, prostatitis, benign prostatic hypertrophy, digital rectal examination, prostate operation, prostate cancer, ejaculation, exercise. So lots of things can increase or give false positive PSA. When not to do PSA, if someone is having UTI, then we should wait for the urinary tract infection to resolve completely and then do PSA. If someone had ejaculation within 48 hours, within 2 days, we should not do PSA immediately after examining prostate by PR examination. We should wait for 1 week, and we should not do PSA within 6 weeks of prostate biopsy. Because of the trauma to the prostate, the PSA will go high. Cancer of the prostate, it's common. 10,000 men in a year in UK is killed due to prostate cancer, so it's quite a lot. 10-year survival rate is good, 84%. And 1 in 8 men will have cancer without any symptoms during their lifetime. And obviously the risk factor is age. With rising age increases the risk of prostate cancer. Race, Afro-Caribbean, first degree relative affected. So it has to be first degree. That means father or brother, not uncle or cousin or anything. So any first degree relative affected, then it increases risk of prostate cancer. Symptoms, we all know, they're in early stage, there may not be any symptoms, like we saw the gentleman who presented with abdominal pain and neck swelling. He didn't have any urinary symptoms, but he had aggressive cancer. It can cause prostatism, urinary retention, hematuria, or if it metastasizes, then it can present with bone pain, pathological fracture, and spinal cord compression. Benign prostatic hypertrophy, it could be asymptomatic or it can cause lower urinary tract symptoms. We have already discussed the treatment for benign prostatic hypertrophy. Because prostate is enlarged, the mainstay of treatment, medical treatment, is 5-alpha reductase inhibitor, finasteride or dutasteride, or transurethral dissection of prostate or other form of prostatectomy. You can use alpha blocker in combination with 5-alpha reductase inhibitor, but 5-alpha reductase inhibitor is the mainstay of medical treatment. Testis. So epididymoorchitis It's due to retrograde infection. So from urethra, prostate, seminal vesicle, it goes up and causes epididymoarthritis. Positive organism, gonococcus, E. coli, streptococcus, staphylococcus, tuberculosis. So adequate treatment, same thing with epididymoarthritis. We should give at least 2 weeks of antibiotic. Epididymoarthritis caused by virus, mumps virus, can cause infertility because it damages the testicular tissue. So if someone had mumps and swelling of the neck, and then if they complain of pain in the testicle, then it is possible that it can cause it is due to epididymoarthritis, and in future, those child or adolescents may develop infertility. Tumors of testis, this is very important because 1% of all malignant tumors in male is testicular tumor, but 99% of testicular tumors are malignant. So if someone has testicular tumor, it's most likely to be malignant. Yesterday, I saw in the Facebook some of the doctors from Myanmar wrote about the boy with testicular swelling, be careful. Yes, absolutely. So testicular swelling, if we detect testicular swelling, if it is not infective, if it is a tumor, it's most likely to be malignant. So testicular cancer, more common tumor in young and middle-aged men. So it's not old age, it's young and middle age. There are various types like germ cell tumors, lymphoma, solid tumors, and it increases, the risk is increased if the child has undescended or maldescended testes. Symptoms, it's a painless swelling of the testis, solid mass. If we feel any solid swelling in the testis, then immediate referral to urologist on suspected cancer pathway. You can do scrotal, or the urologist will do scrotal ultrasound scan, tumor markers like alpha fetoprotein, beta HCG, lactate dehydrogenase. Biopsy may be required, and they need a CT chest and abdomen and pelvis for staging because it can rapidly spread. Treatment options are orchidectomy, chemotherapy, or radiotherapy. Penis, we should not forget about the medical or conditions related to penis. So penis, there could be problem with foreskin, phimosis, paraphimosis in children, and they can present with acute retention, irritation, swelling, ballooning of the foreskin, and they may need operation, circumcision. If someone develops phimosis or paraphimosis in old age or in middle age, that's a red herring. That's a very risky situation because normally men, middle age or old age men don't get phimosis. So if they get phimosis, it could be due to recurrent infection in the glans penis, that is balanitis, and that could be due to diabetes or immunocompromised state, or it could be due to cancer of the penis. So if we see a phimosis in a, not in a child, but in an adult, we usually treat with steroid and antibiotic for 2 weeks, and then we re-examine. If we can retract the skin and can see up to the corona radiator, that's fine. If we can't see, then we usually refer to the urologist because there could be some lesion, some ulceration or malignant lesion on the head of the penis. Priapism is painful erection, which can cause a lot of distress. I mentioned it because I said that a lot of men suffer from erectile dysfunction. And for that, we use phosphodiesterase 5 inhibitor like sildenafil or Viagra. Now, if someone takes more than one Viagra in 24 hours, so excess use of Viagra in a short period of time can cause painful erection. So one need to be careful when we prescribe Viagra type of medicine. We always tell them not to take more than one in 24 hours. Hypospadias, epispadias usually presented in children where there is abnormality in the opening of the urethra. Balanitis, I already mentioned. The other thing, what I would like to mention, that in general practice, in hospital medicine, now we are using SGLT2 inhibitor, sodium glucose co-transporter inhibitor, for treatment of diabetes and heart failure, like dapagliflozin, empagliflozin, canagliflozin. So these medicines increase because it causes the sugar or glucose to come out in the urine. That increases risk of candidiasis in the penis or in the foreskin. So they can develop recurrent infection, and that can lead to phimosis. So just to bear in mind that if someone is taking dapagliflozin and if they complain of any symptom around penis, we need to examine, and if necessary, if it is recurrent infection, we may have to stop that medicine. Penile cancer, it is rare, about 500 cases each year reported in UK. Consider a suspected cancer and do a two-week wait referral if there is a penile mass or ulcerated lesion which is not due to sexually transmitted infection, or if the lesion persists after treatment of sexually transmitted infection. And if in adult, if we see phimosis, we must examine the glans penis thoroughly to make sure that there is no ulcer or cancer underneath. Fourniers gangrene, and this is a condition which affects the perineal, perianal, and scrotal region and genital region and groin. It is a condition, serious condition of necrotizing fasciitis. I mentioned it, it's very uncommon, but now with the use of SGLT2 inhibitor, like dapagliflozin, empagliflozin, that slightly increases risk of developing Fournier's gangrene. So if we use SGLT2 inhibitor, then we always tell patient that if they see any redness, any hot red area around the genital area, they need to report it. Thank you. Sorry, I probably was going a bit fast because there are so many slides so many things to discuss. But I tried to pick up the main areas which we encounter in general practice.
That was very good, Subia. There's a lot, just in men, the lower urinary, men's urinary tract symptoms. There's quite a lot, and I think you've covered the whole spectrum of it. And I hope this has helped GPs. You can probably look at the webinar again, and it might make you think again. I don't see any questions in the chat, actually.
I could not cover the erectile dysfunction, so.
Yeah, maybe we can do that,
Yeah.
and we will ask them. Sarah, maybe I should chat him at him, don't more let out be maybe I should. Sarah, good night. I love the Segama, the Muda in the location, 2 hours. တွေ့ရရင်ဘယ်လိုခက်ခဲလေးရှိလဲနည်းနည်းလေး share လုပ်ပေးမလား to see if they're just checking it to see if they see enough men's problems and any problems or any advice they want.
Sure, thanks.
ဆရာဟင်းခုကိုတွေ့လား GP ထဲမှာတော်တော်လာတာအမျိုးသားတွေဒီလိုအမျိုးသားဒီ problem တွေနဲ့အသက်ကြီးတဲ့အမျိုးသားတွေတို့ prostate တို့စီကိစ္စတွေပတ်သက်လို့ပေါ့နော်
လာပါတယ်ဆရာဟုတ်ကဲ့ဟို stone တွေလည်းလာတယ် hematuria တွေ prostate တွေကတော့တော်တော်လာပါတယ်ဆရာ
PSA ကတော့လုပ်လို့ရလားနေရာတကာမှာ
PSA ကဒီမှာ free ရော total ရောနှစ်ခုလုံးရပါတယ်ဆရာ
Okay, so they can get PSAs in most towns, they can get it done, yeah. Ultrasound, I'm sure lower women, no? Neuroma or ultrasound or yama.
Oh, she was, yeah.
Somebody about bladder training, actually. Choice of antibiotics for epidermal otitis. I think you put it in there already, Subia. Choice of
Yeah,
antibiotics for
It
epididymitis.
is mainly ciprofloxacin, doxycycline,
Yeah,
or coamoxiclav.
yeah.
And about the bladder training, it's mainly to encourage them to try to hold a bit longer each time so that the bladder capacity increases, and also to do pelvic floor exercise like squeezing the pelvic floor muscles, holding it for 10-15 seconds, and gradually relax. In UK, obviously, we send the leaflet. So we have got leaflet about bladder training and bladder exercise, pelvic floor exercise. We usually send a leaflet about that. But just for simplicity, you can just ask them to hold the urine for a bit longer, maybe 10-15 minutes longer each time, so that the capacity gets better, and to contract the pelvic muscles. Like if they need to open bowel, but they can't do then, what they do, they squeeze the tail end muscles. So squeeze those muscles, hold it for a few seconds and relax. So if they do it 10-15 times in the morning, 10-15 times in the evening, that will improve the power of the pelvic floor muscles.
Maybe I'll translate the pelvic floor exercises here and the area. Follow who so wow, Jung Havo, no? I let Jung Bro on Tare solution. Jung like short like Lolution. That solution I who pelvic floor muscle, yeah, Bubro Gownable. I don't early so wow, Jung like short like early look early. You are less beyond the best. See you live. Can I come the body in my canal of sound her on her? Sangamli out to young low. Now, I will out to young low.
Dr. Momokain has put a comment. It's very interesting. I have learned from this because what she's saying that penile ulcer is common in Myanmar because of use of oily injection to increase penile size. So yeah, that's very interesting. So if it causes ballooning of the penis, probably there will be friction and that will cause ulceration.
Yeah, I think these oil injections must also cause a local reaction and affect the
Reaction as
penile.
well.
Yes,
Yeah.
in the long run, they will have erectile problems. I can just see that if they do a lot of this. Yeah, because it's
Yeah.
it's an irritant and will cause fibrosis and poor blood supply to the penis.
Yeah. Thank you, Dr. Momokain.
Sarah, Malaysia Messi lam the Malaysia machine or not a webinar biology and Israel chat him on Nelly Tebiwa. So I'll ask them to put in the chat what other topics they would like. Sarah Gushila Mela March and already chronic kidney disease patelo webinar Kushi, your upper GI, but not dyspepsia and the Samachi and gastric ulcer, John, general Milare Mapiome. June Maro, general pediatric emergency, or not declaring nepathy emergency, Aleo, Jodomis, Guru, Josavi Tepijavas. Mazia Mishio, I think. Okay. Thank you very much, Sabir, for you giving us your time and your very useful talk. Thank you.
Thank you very much, Dr. Ang, for giving me a chance to talk.